Good day, everyone. Welcome to the Strategies for Policing Innovation webinar on taking collaboration to the next level. My name is Chip Calderon. I'm the Managing Director for Justice Programs at the CNA Institute for Public Research, the Director of Technical Assistance for the Bureau of Justice Assistance Strategies for Policing Innovation, and I will provide the introduction for today's webinar. As many of you know, this is one of a series of webinars sponsored by the Bureau of Justice Assistance and coordinated by CNA, the technical assistance and training provider for the Bureau's Strategies for Policing Innovation initiative, which I will refer to as SPI. As the title suggests, we in SPI have been working on collaboration issues for some time, and we have conducted webinars on this topic in the past. We return to this topic in our SPI webinar series for several reasons. One, we have new SPI sites and new colleagues working with us since we last presented on this topic. It makes sense to refresh our understanding and revisit the topic from time to time. Two, we have learned more about collaboration, so it makes sense to discuss what we're learning. And three, in some ways, collaboration has taken on a more prominent role in American policing. Proudly, SPI is at the forefront of these developments. For these reasons and more, we feel it is timely to revisit the collaboration topic and, as our title suggests, advance the concept of collaboration in SPI. We will hear from several of our sites and colleagues today. Hildy Saizow, a senior subject expert with SPI and our collaboration guru, will help set the context for what we will learn from our other colleagues. Shyla Hawk from Applied Research Services in Atlanta and the research partner with Atlanta SPI will discuss their approach to measuring and improving collaboration related to their hospital-based violence prevention program. Sergeant Jolene Bowman from the Mental Health Unit in the Pinellas County Sheriff's Office will discuss collaboration issues relating to their SPI initiative, the Chronic Consumer Mitigation Project. Brenda Bond, SPI expert and research partner with the Lowell Massachusetts SPI initiative, will discuss one approach to building and assessing collaboration that she has applied and studied in several contexts. Emma Wall, a researcher at CNA and our SPI outreach coordinator, will help facilitate a question and answer session following these presentations. I will then offer some closing and summary remarks. As you can see, we have an impressive lineup here, with much to offer based on research and experience regarding new and innovative ways to develop, support, and evaluate collaboration. Please let me thank each of these individuals for sharing their knowledge with us and for helping develop this webinar. Thanks also to Christopher Sun, Charles Stevenson, Mia Hicks, Emma Wall, and others who assist with the development and delivery of our webinars. We also thank Kate McNamee and the Bureau of Justice Assistance for their long-standing support for SPI. Permit me to make a few other comments. This webinar is recorded for the benefit of others who may view it later on our website. There will be opportunities for questions and participation during the webinar, so please make your thoughts and questions known. I can assure you that others will appreciate hearing what you have to say. Feel free to voice your comments and questions during the question and answer session or to use the chat function at any time during the webinar. Immediately following the webinar, you will receive a request to evaluate it. Please complete the evaluation and please give us your honest thoughts and recommendations, as well as suggestions you may have for future webinar topics. Now let me hand the presentation over to Emma for a few other technical details.
Thank you, Chip, and thank you to our participants and presenters for joining us today. As a reminder, please mute your phones during the webinar. You can either do this using the mute button on your phone or by pressing *6 on your keypad. At the end of the webinar, there will be a Q&A portion. You can either unmute yourself by pressing #6, or you can send your questions in through the Q&A or the chat functions on the webinar. If you have any technical issues, please chat the Strategies for Policing Innovation account in the lower right-hand corner of your screen. As Chip noted, this webinar is recorded, and we will post the recording of the webinar on the SPI website soon after today. We will also post the slides from our presenters. Again, at the end of the webinar, you will have the opportunity to complete a survey. Please let us know your thoughts on this webinar as well as future SPI webinars you would like to view. I will now turn it over to Hildy Saizow to begin our presentation.
Thank you, Emma, and thank you, Chip, for that introduction. It's great to be here today to talk about one of my favorite topics, collaboration. I've been asked to set the context for today's discussion and define what we mean by taking collaboration to the next level. I'm excited to play this role because much of my professional work and experience has been aimed at improving police-community relations. And it's great that I can say we've come a long, long way in this area and know so much more about how to build successful relationships. In fact, in this era of limited public resources, data-driven approaches, and the focus on addressing root causes of crime, collaboration is more essential than ever to public safety. Now, most police agencies engage the community in one way or another, but typically this engagement is fairly basic, involving community outreach, information sharing, coordination, perhaps some consultation. But collaboration, on the other hand, is really something quite different. It requires much more sophisticated partnerships, shared responsibilities, and shared decision-making between the community and the police. Now, to unpack these issues and provide guidance to agencies, SPI organized 3 regional workshops back in 2016 when conflicts between police and communities were regularly seen in the media. Law enforcement and community representatives from more than 25 jurisdictions attended these workshops, where we examined both challenges and successes in police-community collaboration. From this work, SPI fleshed out the construct of collaborative policing and identified what it takes to implement this new approach. So here's what I mean. Collaborative policing combines the key elements of collaboration, problem-solving, and evidence-based policing, along with comprehensive partnerships, all so that agencies are able to implement much more effective and long-lasting public safety solutions. Now, no doubt we will hear from the presenters in just a few minutes that collaborative policing is not easy to implement. It takes major effort and a change of orientation for both the agency and the community. But the benefits of successful collaboration are huge. Greater community trust and confidence in the police, more innovative and holistic solutions, more community cooperation in the justice system generally, to name just a few. So to help agencies put collaborative policing into practice, SPI developed 8 key principles based on what we learned in the 2016 workshops. If integrated, these principles can help agencies transform and become collaborative policing agencies. Now, here are the 8 collaboration principles, and I'll go over each of them briefly. Principle 1, build strong leadership support. Now, strong leadership is the key to collaborative policing. It's vital that the agency's executives, but also the senior and even mid-level managers understand, buy into, promote, and model collaboration, in particular to influence the behavior and activities of the patrol officers who are out there in the community and on the street on a daily basis. Principle 2, orient towards service. So to be truly collaborative, both the agency and individual officers must change their orientation. This means agencies develop a service model where they work with community-based service providers to develop comprehensive solutions to those difficult problems, things like opioid abuse, youth violence, mental illness, etc. It also means individual officers play a more helpful and service-oriented role in the community rather than serving solely as crime fighters. Principle 3, transform training. Now, both in the academy and in service, Training should be reconfigured to build those skills necessary to support collaborative policing. This includes blocks of training time that are focused on a whole slew of areas: social interaction, communication and empathy, de-escalation, trauma-informed approaches, implicit bias, problem solving, and so on. Principle 4, build community relationships. Now, no practice is more vital to law enforcement than the building of positive community relationships. And to do this well, officers have to get out of their cars and engage in regular face-to-face contact. They have to be good listeners, and they need to show community members that they care and empathize with their problems and concerns. One particularly powerful approach to problem solving involves what we call multi-sector collaboration, where a police agency builds strong relationships with service agencies. And we have some great examples of multi-sector collaboration to share with you in just a few minutes. Principle 5, proactively engage with diverse communities. Building relationships and trust with people of different races, different ethnicities, religions, and backgrounds is also an essential component. This often requires rather focused strategies, but that depends on the history and culture of the groups being served, becoming more aware, perhaps, of poor living conditions in the local area, creating an ongoing dialogue with community members, etc. Principle 6, improve communication and messaging. Communication strategies, particularly the use of social media today, can be very powerful tools for promoting community interaction, for building relationships, for highlighting those positive actions that officers take every single day, and even reaching hard-to-reach groups that won't usually attend meetings. Principle 7, understand community perspective. Quite often, the community's perspective on issues differs from that of the department. So taking the time and investing the resources to learn community perspectives is also key to collaborative policing. A variety of methods can be used to do this, things like surveys, focus groups, informal street corner sessions, structured dialogues, and so on. And finally, Principle 8, view the community as an equal partner. Both police and community members have a serious stake in creating safe communities. While police are usually the ones that start or facilitate or even organize collaborative efforts, it's also critical that community members take on really important roles in the process, whether as partners, supporters, or decision makers. So with these 8 principles in mind, we have 3 SPI projects to present to you. Although very different from one another, each project exemplifies and vividly illustrates collaborative policing. And one additional thing to listen for, as Chip mentioned, it's really important to SPI, and so we highlight it today, is the ability to evaluate collaboration in order to continually improve the process and identify those key outcomes, impacts, and successes of the collaborative approach. With that, let me turn this over to my colleague, Shyla Hawk from Atlanta.
Thank you all for being here. I'm Shyla Hawk with Applied Research Services. IRS serves as the research partner for the Atlanta SPI, and this portion of the webinar will be about the innovative way the Atlanta Police Department is using collaboration to address gun violence. The effectiveness of any evaluation begins with defining the goals, so I will start with those for the Atlanta SPI. Then I'll briefly walk you through how it's structured and the stakeholders involved, how we got trust built among everybody, and the SPI is embracing critical elements of collaborative policing. Then I'll go into some types of collaborative challenges and suggestions for how to overcome them. To conclude, I will cover the assessments that we use in our collaboration to regularly talk about any challenges and look for continuous improvement. The Atlanta SPI team has worked to create Pivot Atlanta. It's the program to interrupt violence through outreach and treatment. Pivot aims to reduce gun violence through a coordinated public health model for prevention, which acknowledges that gun violence can spread like a contagion following a single violent event and then through social interactions and personal networks. As such, the program's message focuses on shifting attitudes of public health providers and law enforcement officials to view violence as a public health issue, and improving public health through the provision of services among people and the communities at risk of repeat gun violence. Collaboration was developed to provide wraparound services with intense follow-up for shooting victims, concentrate community policing and support in victimized neighborhoods, and embed data sharing. The goals of these efforts are to develop a strong relationship among city service providers, improve and expand agencies' understandings of the problem and related factors, and increase police legitimacy. Ultimately, the collaboration hopes to reduce trauma of gun violence experienced by individuals and their communities and lower the cost of public health. Gun violence is not necessarily a new issue to the City of Atlanta. However, the Pivot collaboration arose from an alarm shared by police leadership and Atlanta physicians regarding a rapid growth in firearm crimes. Atlanta police were searching for an innovative and data-driven approach to respond to violent injury hotspots, and at the same time, Atlanta physicians were seeking an intervention to address the underlying trauma of violence and repeat patients. With the help of fiscal and research partners, the task force is now an equal representation of the teams of people managing those involved in firearm-related violence. Decisions are brought before the task force for collective decision and discussion before implementation. The Pivot stakeholders are from the Criminal Justice Coordinating Council serving as the fiscal agent. At the Atlanta Police Department, the primary units engaged are gangs, gun reduction, the zone investigations, community-oriented policing, and the crime analysis unit. The Grady Memorial Hospital stakeholders are positioned in social work, injury prevention, orthopedics, emergency medicine, trauma, paramedics, and more. Applied Research Services, Emory University, community-based social service providers, such as those providing education and mental health programming, leaders from churches, neighborhood associations, and community centers. Stakeholders also include Annie Casey Foundation and the Atlanta Police Foundation, as they've been supportive of the project since conception. And lastly, the Georgia criminal justice system is interested in information sharing and programming that increases public safety and decreases expenses. So while there are many ways to build trust, here are some of the ways that we did it. We started out by outlining the evidence of what was the problem and how it's been previously addressed. We found that this was an objective and welcoming way to invite people to the table. Cohesion got easier as we articulated a shared mission. Knowledge that all parties might benefit from the collaboration linked partners' priorities, and there needs to be clear goals and timelines because uncertainty, we found, can erode diligence and introduce redundancies or wasted efforts. And most importantly for a foundation was starting with good faith as we built trust by giving it to one another. Once we had a foundation, we framed it with routine, open, and honest communications. We found there will always be operational battles, but we treat them as debates. The task force is a safe place to hash out ideas and consider alternative perspectives. Those conditions are only possible when we clearly define the roles and responsibilities of each partner. Anytime people have to presume or assume, there will likely be negative emotions or less favorable decisions. And we celebrate diversity of skills and input from teammates that help us think innovatively and interact respectfully. Then the way that we sustain this trust is by people continuing to show up, be attentive, and deliver on promises. Timely responses keep the momentum going, and we build in assessments of the collaboration health to help keep us informed or to help identify any lingering issues before they worsen. Finally, we found that appreciation goes a really long way, so that acknowledging hard work has been instrumental. The collaborating police department is the largest in the state, and the hospital is the premier level 1 trauma center. So these leading agencies have a lot of pull to get things done in the city. In addition to that, we have managers from various levels of each organization, and we have 4 full-time positions for Pivot funded through the Atlanta SPI. Given all of the moving parts for the initiative and data sharing, a project coordinator was required. Leaders at APD include the Crime Analysis Unit Commander and 2 focused community-oriented policing officers who spend their days building relationships in the at-risk communities and in response to gun violence incidents. For the hospital-linked side, the Community Resource Coordinator responds to patients' bedside and does soft handoff referrals for services. The entire program is devoted to service provision. The Pivot officers are not making arrests or writing citations to suppress crime in hotspots. They consider themselves to be protectors of people traumatized by shooting, which include those who might even retaliate. They wear more casual clothing, and I always find that they're smiling. They are willing to go up and just have conversations with people, as they serve as mentors, interrupters, resource guides, and brokers between the families and the justice system. They seek to cool tempers after the aftermath of a shooting and continuously look for ways to improve quality of life for everybody in their communities. The collaboration has required a great deal of knowledge building, which continues formally and informally. The agencies had to train each other on their language and their experiences. The staff had to listen to the communities, understand what services were available, and when and how they should be offered. The Best Practices Work Group promotes evidence-based decision-making and disseminates findings to everyone regularly. Those include opportunities to learn from other experts, other programs, and other fields. For example, the police have participated in a trauma-informed criminal justice response training that you might have read about in the last SPI newsletter. The officers also attend and are present at various conferences and public meetings in public health and criminology. They co-opted a learning series at Grady, which overlays education as well, and one of those sessions was even devoted to helping hospital staff understand activities that might be group involved aftermath of a shooting. It should be apparent that this collaboration hinges on the breadth of relationships with any and everyone that can help reduce risk and increase protective factors related to gun violence. The officers regularly collaborate in meetings with Pivot partners, support the hospital staff to treat individuals, and are an integral part of the resource referral group. They also hold and attend community forums to spread the Pivot narrative and facilitate face time with residents. Gun violence victimization disproportionately affects certain demographics and communities already facing layers of hardship in Atlanta. To help those most at risk, analysis showed that patients from certain zip codes were at higher odds of exposure to recurrent gun violence, and 3 neighborhoods needed special attention, so we prioritized those. As a goal of the project is to change the narrative around gun violence, and Pivot requires community cooperation, we do a lot of outreach. Community building events are held in the target areas, as well as a maintained presence in the community organization events, community organized events, and a lot of street time. In-reach is also key, so partner presentations are common occurrence. There have been some media interviews, handouts, and other literature developed as well. These efforts have helped to expand knowledge and interest in the program for the long term. In fact, just yesterday, a Senate resolution was passed in honor of Pivot. Communications and messaging also provide opportunities to understand community perspective. Pivot officers have informal street corner sessions, canvass for information, and make regular contacts in the at-risk communities. Community surveying has also helped the task force to understand residents and their concerns. Since you all get a copy of this presentation, I went ahead and added the full community survey here for you to review and use as you like. The survey was pre-tested on a Project Safe neighborhood site, and then it was administered using a multi-method approach. The task force used it to learn about the at-risk communities, to what extent they had had previous interaction with the police, their opinions of the police, how much they fear crime or had been victimized, and thought that the major problems were. So at every stage, we've encountered challenges. Every collaboration will. Here are some of the ways that we overcome them. For inadequate communication, try setting a standard date and time for meetings, and then be also open to different types of communication, such as using GoToMeeting or something similar to that instead of everybody traveling to be in person. Also, collaboration apps they're free ones, and it's easy to keep track of project deliverables. Although the hospital and the police department both live and breathe bureaucracy, hierarchy, and emergent response, we found that they don't actually walk alike or talk alike. So we have to take great care to explain and understand to all partners. We've had turnover at nearly every level of the police department and some key positions within the hospital. We found that turnover can be mitigated with a clear onboarding process. We use a welcome packet that includes a summary of the project, its current status, a decision tree with contact points, MOUs, a design of the process, and important upcoming dates. Sometimes special meetings are warranted as well. As the project develops, so will the roles and responsibilities. We found that you need to constantly keep those clearly defined. The novelty of our project also slowed down development at a particular point, such as in development of standard operating procedures and data requests. Those were slowed because the approval process needed to be more thoroughly explained and vetted. We found that keeping the message consistent and persistent helps avoid confusion. In hindsight, we set some hard deadlines that kind of started to snowball, but things got better whenever the task force became more flexible and resourceful. We also have a lot of passionate people, and sometimes that means that we develop a kitchen sink syndrome. But we found that you can mitigate that if you have defined guidelines that will help your team stay on track. But automate documentation as much as possible to be consistent and thorough without overburdening. If you look for out-of-the-box ideas, you'll be able to find ways to do more with less or be able to distribute the responsibility among partners. Coordinating the schedules of cops and doctors has been a beast, so we use all kinds of electronic tools. We use doodle poll and call-ins, texts, emails, and even the collaboration apps. You have to be open to communicating in all possible ways with your partners in order to make sure that you're communicating well. Transparency and team building take extra time, but they'll strengthen the team so that challenges are speed bumps and not walls. We've done icebreakers, interpersonal time during conferences and trainings, and even excursion that we found really helps. And lastly, having all agencies report out regularly holds people accountable, and communicating about all the aspects of the process will help the team to stay on the same page. So in terms of our assessment and how we use them to improve, Pivot follows the SARA model of problem solving, scanning, analysis, response, and assessment, meaning that we regularly measure Pivot progress and discuss ways that we might be able to improve. To find the best decisions, we always search for whatever evidence we can, either in the literature that somebody else has done or in just using database decision making, such as we monitor shooting counts at both agencies, where the gaps in those incident reports are, and how the responses are going or not. For example, Pivot staff monitor how many shooting patients arrive at Grady Hospital, how many are eligible for the program using a screener, and how many of those eligible patients are enrolled in the program. If the numbers start to significantly veer, then the task force investigates and looks to problem solve. In addition to quantitative data, we also value qualitative data. Process shadowing and individual or focus group interview data are collected regularly to make any mid-course corrections and ensure long-term program fidelity. We find it's essential to have an information feedback loop with key personnel to drive strategic planning and commitment. So we measure collaborative policing activities in the field using a end-of-shift report. The officers help design a 30-item summary of Pivot contacts and communications. The data help us to define their role in the communities and the partnership. This helps the larger collaboration to understand the officers' work, but it also keeps the officers themselves accountable for time in each of the 3 communities. We've used these reports to identify issues as well, such as the officers being pulled from the program for special assignments, or them needing to do more networking with service providers. We found this to be so useful that we actually just implemented a similar tool for our community resource coordinator. And the last assessment that I'll talk about, we use the Wilder Collaborative Factor Inventory Survey as it's a common tool for assessing the functionality of collaborations. The survey consists of 40 Likert items scaled relative to factors about collaboration health. Those range from trust and respect, flexibility, pace of development, communications, leadership, and legitimacy. Surveys are collected from task force members every 6 months, and findings are presented for discussion. If a factor trends in the wrong direction, follow-up interviews are conducted to make sure that recommendations for policy and practice are appropriate. For instance, during the planning period, there were 7 core task force members, and then when we went to pilot, we had doubled in size. The Wilder survey picked up on some confusion around roles and responsibilities, so we conducted interviews with each of the respondents for more detail and suggestions. Those findings in aggregate were then presented to the group, and everyone decided to go around the table and present what they thought their own role and responsibilities were for the feedback of the larger team, and then later we used that to craft a charter and make necessary clarifications for improvement. Okay, that's my time for Atlanta SPI. Thank you.
And I'm assigned to our mental health unit. I'll be addressing how we use collaborative policing efforts to assist those in our community who have mental illness. So the goal of the mental health unit at our agency is to connect people with mental illness or persons experiencing a mental crisis with appropriate services. We want to reduce the chances of recidivism for those who suffer from mental illness. To do this, we needed to reduce the number of Baker Acts for clients. A Baker Act is an involuntary evaluation in the state of Florida. Reducing the number of involuntary evaluations, in turn, would reduce the number of law enforcement calls for service that involve mental health. The mental health unit is one of the smallest squads in the Pinellas County Sheriff's Office. It consists of 1 sergeant, 1 corporal, and 2 teams. Each of our teams is comprised of a deputy and a mental health navigator. The navigators are master's level counselors who are contracted with our agency from a local mental health provider. Well, it was determined that our law enforcement officers would operate in uniform as opposed to plain clothes. Our agency still wanted to provide a softer approach when contacting persons in need of services. So instead of wearing our formal Class A uniforms, we wear polos and BDU pants. This is the same uniform that our approachable community policing deputies wear. We drive unmarked cruisers that are completely outfitted with emergency equipment in case we need to respond in emergency mode. We are aware that there's a stigma associated when people are in contact with the police, so we do our best to minimize that. We also had to determine how we were going to function as a unit to meet our goal. The mental health unit initially deployed in a geographical area that was identified as being densely populated with persons who have been taken into protective custody for involuntary evaluations. The teams responded to in-progress mental health calls that were dispatched within this area. The mental health unit teams would try to conduct follow-ups with these individuals who they had contact with on these calls. This was a very difficult process as the number of persons the team had contact with continually grew. The teams provided consumers with informational packets that contained services that were available to them. These teams were finding that there were several individuals who did not take any further action to connect themselves with any additional services. During this process, deputies documented data related to these individuals. Some of this data consisted of consumer demographics, medications, and diagnosis. The data being collected at this time made it difficult to determine whether the mental health unit was having a positive impact on the mental health community. The mental health unit transitioned to a new set of clientele at the beginning of January 2018. A specific population was then identified. Clients that we contacted were those who had 3 or more involuntary examinations to include Marchman acts, which are for substance use, attempted suicides, overdoses, and ex partes within the last 2 years. We focused on adults who were not transient and did not live in an assisted living facility. We needed to find a population that we could track and be able to conduct follow-ups with. The mental health unit deputies compiled data on these consumers that included police contacts, arrests, and involuntary evaluations for the 2 years prior to our squad having contact with them at the start of 2018. The deputies then continued to document the same data for the consumers moving forward from their initial contact with them. The navigators who work with the mental health unit are contracted from the local mental health provider, Directions for Living. This agency is one of 2 major providers in the county that accepts any client no matter what their socioeconomic status. A benefit of contracting with this agency is that the mental health unit's clients would be provided faster connections to services offered by this agency. The navigators have the ability to complete intakes and safety plans with the clients in the field. This makes the process easier on the client. An intake can take up to 4 hours. Being able to complete an intake in the comfort of the client's home makes the experience less aggravating for the client and reduces the chances of the client backing out of the process. As the grant came to a conclusion, our sheriff has chosen to keep this partnership with Directions for Living as we continue to move forward with our mission. In 2018, a new team was developed in our county called the Pinellas Integrated Care Alliance Team, or the PIC team. The purpose of the PIC team is to implement a collaborative system of care model that directly addresses gaps, health inequities, silos, and redundancies in the existing system of care in Pinellas County. This team consists of 9 case managers from 3 different mental health providers in the area and 1 peer specialist. The case managers on this team provide intensive case management. The current average caseload is 9 clients. Since the mental health unit's connection with the PIC team, we have been able to engage more clients. Clients who sign releases with the PIC team allows for us to communicate between agencies so that we can do what is necessary to get the client the best coordination of care. We also partner with the University of South Florida. On a quarterly basis, I provided the data collected by the mental health unit teams to Dr. Scott Young with the university. He is currently in the process of completing the analysis for this project. Dr. Young expressed interest in having a full year of data on our new and latest operational method for the selected population. The mental health unit continued to track and engage these individuals through the end of 2018, and we're looking forward to seeing the results. One of the most important tasks that the mental health teams take part in is the engagement process. This can be a very difficult process. Some of the clients immediately accept our assistance, others decline, and some waver back and forth. Once the team is able to engage a client, the navigator assesses for what is lacking that is causing the client to go into crisis as often as they do. Some clients have advised that they need more therapy, some said that they do not have rights to their treatment, and others have even mentioned that they don't have health care insurance to cover the services they need. These are just a few of the deficiencies we have had clients inform us of. The first half of this year, the mental health unit teams performed case management-like activity on a daily basis. They did their best to connect the clients with the services they needed. They drove clients to intake sessions. They assisted them with obtaining a local health care or insurance card, and they even completed applications for them so that they could begin services needed. In July, the relationship with the PIC team began, and they were able to provide another positive change to our unit here. Due to the members of the PIC team being able to carry that caseload of 9 clients, the amount of case management being conducted by the mental health unit was reduced drastically. The mental health unit has been able to refer many clients to this team, which has resulted in a lot more clients being connected to services. Other functions that the mental health unit are involved in have allowed us to build relationships with community partners. We attend weekly meetings with representatives from several mental health providers in the area. Programs and services are discussed during these meetings. This educates everyone on programs they might not have known were available. The mental health unit also assists with crisis intervention team training. We often role play and provide guidance to law enforcement officers who are learning how to engage and communicate with persons who have mental illness. We also recently began the oversight of another training. This is the Mental Health First Aid course, which is an 8-hour length course. The training is a shortened version of CIT that our deputies are all being trained in. There were some challenges experienced throughout our journey. One of concern was determining how to measure our success. We had to determine what data could be recorded that is measured other than the client's demographics, or that's measurable, other than the client's demographics. The mental health unit tracked arrests and days of incarceration, involuntary evaluations, and negative contacts with law enforcement. We define the negative contacts with law enforcement as any contact the client had with an officer as a result of their mental health. We did not include any contacts where the client was listed as a victim, complainant, or witness. The mental health unit also tracked the number of times that the client or the client's family called us directly for assistance as opposed to calling for patrol response. This aided in reducing the number of calls for service for patrol. We were able to track the client's health care insurance status. We documented if they needed health care, if they have applied for insurance, and whether or not they were qualified to receive it. We also documented what services the clients were connected to. The mental health unit monitored and logged the phase each client was in with every contact they had. We identified and defined these phases as being crisis, maintenance, stabilization, and closed. The crisis phase was defined as when an individual has been identified as having a mental health crisis. The individual is believed to have a mental illness who displayed one or more of the following: having delusions, exhibiting erratic behavior, creating a disturbance, real and present threat to substantial harm due to self-neglect, threatening harm to oneself or others, or displays other activity or behavior that causes alarm. The mental health unit would contact the individual at a frequency necessary to help the person reach the maintenance phase. The maintenance phase is described as when the individual is in the process of being connected to services and programs to aid them in gaining stabilization. Weekly follow-ups would be conducted. This could be done by a telephone call, a face-to-face meeting, or contact made with a reliable acquaintance of the individual. The stabilization phase applies when the consumer has been connected with services. They're participating in a mental health program and has reached stabilization. The mental health unit would conduct monthly follow-ups until it's determined that no more assistance is needed from our mental health unit. And then some various reasons as to why our cases would be closed would include if the client is non-compliant, they're deemed stabilized, they've moved out of county, or are incarcerated for a lengthy period of time. This information was tracked for all clients who were in our initial selected population at the beginning of 2018. This included those who were not compliant and refused assistance from the mental health unit. As mentioned earlier in the presentation, the engagement process was found to be difficult and repetitive at times. It was not easy getting people to trust law enforcement or even feel comfortable with law enforcement coming around their house on a frequent basis to check on their well-being. The PIC team has been a huge benefit in this area. They're able to respond to clients' residences without the neighbors knowing who they are or why they are even there. Another challenge has been turnaround in personnel. For those of you who work with or within law enforcement agencies, you know that transfers occur on a regular basis. During my time working in the mental health unit, 2 deputies have retired, another is transferred to another agency. The same thing occurs within the mental health field. The mental health unit has 2 different navigators now from when the program started. Other employment opportunities presented themselves, and job security was a fear. The therapist did not know how long this program would be in practice. There was a concern as to whether or not it would continue once the grant was completed. I believe the mental health unit had a positive impact on many of our clients and also provided further insight to mental health providers as to what's happening with these individuals who have mental illness outside of their facilities. The PIC team has had the opportunity to go to the clients' homes as a part of their case management. Doing so has provided a broader picture of the client's mental welfare. The case managers have seen things that may not have been discussed during or with the client at the time of the meeting them, at the mental health facility or presented in the documentation by a law enforcement officer when they're taken in under an involuntary evaluation. As you see from the numbers, the mental health unit has been able to refer 145 clients in the 6-month period to PIC. The members of the PIC team have openly stated that they were not anticipating the clients being as sick as they are. Accolades have been given to the mental health unit teams for the amount of case management work they completed during their attempt to connect clients with services. 102 clients accepted assistance from PIC. The most successful clients required residential substance use program or an extended involuntary commitment to have the ability to successfully follow through with outpatient services. Not all of the mental health client referrals are made to the PIC team. Our navigators continue to connect clients with services at their agency as well. Directions for Living continues to fast-track clients who are referred from the mental health unit. The navigators have been an asset to our clients as well. These clients now have a direct line to someone from the mental health facility where they're receiving treatment. The navigators also play an important role in a weekly meeting that's held with the PIC team. They represent an agency that does not have a case manager who is a member of the PIC team itself. That being said, during client staffings, the navigators are able to bring up programs and services offered through Directions for Living that may benefit PIC team clients. The mental health unit's relationship with the PIC team has been a wonderful thing. Working together toward providing additional services to mental health consumers has helped the mental health community identify gaps in treatment so that the mentally ill in our community can be provided better services. More mental health programs are beginning to launch in Pinellas County. Our dedication continues to connect mental health consumers with appropriate services to reduce recidivism and law enforcement response to our mental health calls for service. Thank you.
So thanks for spending some time with us this afternoon. I think I may end up echoing many of the things that have already been said in terms of the challenges, but I look forward to hearing questions and feedback after. So today I'll be talking about a model for collaboration that's being used in the Lowell Massachusetts SPI project. I'm one of the research partners working with the city along with my colleagues from the University of Massachusetts in Lowell. We are midway through the work on this project, so most of my report today will reflect our process experiences, so what we're learning in the process. So to frame the discussion, I offered some background on the Lowell SPI study. Lowell is a mid-sized city that is north of Boston with about 110,000 people who live in a very small area. And like many communities or cities, Lowell has been hit really hard by the opioid crisis. So they are using their SPI to test and evaluate an interagency, interdisciplinary outreach effort to both respond to opioid overdoses and to try to help get folks into treatment, and so to share information and with each other to support access to treatment. There are several agencies involved in this effort, and this is a new effort that involves these diverse agencies. So in addition to wanting to learn about the outcomes of the individual's involvement in treatment, we were really interested to learn as much as we could about collaboration as one of those outcomes. So I'll be focused primarily on the collaborative work of the co-op team. And the co-op team, as noted in the previous slide, stands for Community Opioid Outreach Program. So in Lowell on their SPI, they have another effort where they're focused on supporting children who are exposed to opioid overdoses or family members of opioid overdose victims. But today I'll talk primarily about the work of the team and the collaboration. So this visual shows who the co-op partners are, and you can see that it's a diverse partnership of agencies that are all stakeholders in this particular crisis, but they come to this collaboration with very different views and experiences, different trainings, different cultures, different sort of philosophies and ways of thinking about what the best treatment or best intervention looks like. But because they found that they were often sort of showing up at the same places and they're really committed to trying to help this community figure this out, they decided to try something new where they would work together around outreach and treatment. So as you can see, we have the Lowell Health Department, and they are the agency that primarily administers and facilitates the co-op team work, and some of their staff do outreach into the community. Most of the folks on the team will respond within a very short period of time for all overdoses in the community. So there are outreach workers from the Lowell Health Department. Then we have the Lowell Police Department and the Lowell Fire Department, and on most occasions they would normally be responding to an overdose, but then also interacting with family members and others who are affected by this issue. So they also do outreach and referrals as first responders. The Trinity Ambulance is a really new partner in this kind of work, despite the fact that they are first responders and certainly know many of these folks. They've never sort of participated as part of a team, and having them has been great, but of course there are different kinds of challenges in terms of their standards and information sharing. The Greater Lowell Mental Health Association they provide mental health services to overdose victims, family members, and children. And one of the challenges that they're undergoing right now is that agency is sort of merging with another agency, so that's creating some collaboration challenges, but also administrative challenges. And then we have Lowell House, Inc., which is the treatment provider in the community. And then you can see that the research partners are also part of this, not necessarily involved in outreach, but part of the team in terms of trying to understand and help these agencies work together effectively. So as with all good SPI projects, Lowell's logic model really details the complex connections between the challenges that they face, the different strategies that they are hoping to employ, and what their goals are. And so one of the goals, obviously their major goals are to reduce the number of overdoses and trauma that's related to that, increase treatment access, and increase information about treatment. But they also have a goal of increasing their capacity as a city and as a group of agencies to address this particular crisis. They also want to share information, and I think part of what they're trying to do is to build their capacity in a way that helps them in the long run where they might face other types of crises. So the short-term goal would be to build the capacity around this particular issue, but a long-term would be to build their capacity and sustain the relationships between the organizations so that they can adapt to other potential challenges that they may face. So, all of these agencies have realized that they cannot tackle these issues alone or in a vacuum, and that they really do need to collaborate in order to do the work that they are trying to do. So we, as part of the research effort, we are looking at and coming to understand collaboration in the Lowell SPI project through 3 different mechanisms. Obviously, like most SPIs and a lot of projects, there's a lot of materials that we can look at to understand on paper what it is that is happening between the agencies. The agencies that are involved in the co-op program had created an MOU early on, so we're using that, and we're participating in meetings to observe and learn from their interactions and the work that they try to do when they get together in an administrative way. We also are conducting interviews with co-op stakeholders, and those stakeholders sort of fall into 2 different groups. One is those who are receiving treatment, and then also those who are helping to implement it. So I'll talk a little bit later on about some of what we've learned from the partners, the staff of the different agencies. But lastly, and what I'm going to talk about mostly today is the use of relational coordination in this project, and I'll focus on relational coordination, which is a theory and a set of tools to improve work between agencies that are really trying to accomplish shared goals. So our relational coordination is a theory and a set of tools that came about through the research of Jody Hoffer-Geitel at Brandeis University. She's a colleague of mine and a mentor. Jody created the Relational Coordination Research Collaborative with a number of other folks to promote and share what I call RC with researchers and practitioners, and to help to form a network of people who are really interested in learning about collaboration and applying relational coordination to their work. I was introduced to Jody and relational coordination while I was early on studying offender reentry and how different agencies needed to or were working together to create a system of reintegration for offenders who were leaving correctional institutions. And so through that work, I started to really learn about the value of the relational coordination theory in criminal justice contexts. So I wanted to offer this up, this website up as a resource, because there's a number of fantastic resources there around the research and how it's been applied. So relational coordination is grounded in the idea that certain work and work processes or tasks require that people collaborate, and that communication and coordination and the nature of communication and the nature of coordination enhance that collaboration. Ultimately, that collaboration seeks to facilitate the achievement of outcomes of interest. So whatever it is that you are trying to achieve, the nature of that collaboration can really make or break your achievement of those goals. So there's strong evidence in support of relational coordination from across diverse contexts. Early work has started in the airline industry in terms of thinking about how different folks who work in the airline industry need to work together in order to maintain a safe and productive environment. And a lot of work has been done in the healthcare industry. And I personally, as somebody who has worked in the policing sort of field for several decades, I feel like these two particular contexts, the airline industry and the healthcare industry, are very similar to what we see in the complex environment of public health and community safety. I'm currently also testing relational coordination with another Suffolk colleague in the context of youth and gang violence collaboration. So I feel as though what I'm appreciating about this project is there's a lot of potential to learn from this work for the work that's happening in communities. So the relational coordination model looks like this. On the left, you'll see in one box that if organizations or agencies have shared goals, they have shared knowledge about what it is that they're doing and what they're trying to accomplish, and if they're mutually respectful of each other's roles, and if they engage in frequent communication, timely communication, accurate communication, and communication that is problem solving versus blaming, they are more likely to achieve their outcomes of interest. So shared goals, shared knowledge, mutual respect, frequent, timely, accurate, and problem-solving communication really form the heart of relational coordination and how agencies can improve their collaborative work. And so for what we're trying to do in Lowell, we are trying to apply that model of relational coordination to what the co-op team is doing so that they can work better together and ultimately reduce opioid overdoses and support those who are impacted. So we're measuring where the Lowell partners are over time against these RC dimensions using what's called an RC survey instrument. So specifically, we're surveying partners and those close to the co-op team from the partner agencies and asking them to tell us about their communication and coordination with each other. And we're doing that over time. So I'll tell you a little bit about it in a minute, but we did that in 2017 so we could try to get a baseline for what's the nature and the strength of communication and coordination, and then we will repeat that. So the RC survey places people in work groups, and those would be those partner agencies, for example, Lowell Police Department, Lowell Fire Department. And it's interested in putting people in work groups because what's really important about this, and I think speaks to some of the challenges that we have already heard about in terms of staff turnover or staff changes in terms of people moving from one position to another. The RC really seeks to assess the institutional relationships rather than relationships between individuals because, as we know, If one individual has a relationship with somebody in another agency, that might work really well right now, but if that person leaves, then there is either a gap in service or a gap in the relationship. So RC is really emphasizing institutional relationships and the relationships between roles as opposed to between individuals. So this is how we're using the survey in Lowell to help improve what they're doing. And there's an action research element to this where we survey the partners to identify and learn about their collaboration strengths and areas for improvement. We also have been collecting feedback through interviews with stakeholders and pulling that together so that we can make recommendations to the partners about where we're learning, where they have those strengths or where they have those weaknesses. So it's an iterative process that really has an action research component. So here's an example of what we learned from our 2017 our Relational Coordination Survey. And what you can see on the left-hand side is a list of all of the partners. And then at the top, that's vertically. Horizontally, you can see each of those partners as an abbreviation. And the way that the survey works is that each individual who represents a partner agency completes a survey and answers questions about their communication and coordination with the other partner agencies. And they do that on a scale from 1 to 5. So, for example, the Lowell Police Department, somebody from the Lowell Police Department who's working with co-op would fill out a survey, and we would ask them, can you tell us about the nature of your communication and coordination with the Lowell Fire Department? And then we ask, can you tell us about the communication and coordination with Lowell House, with the Lowell Health Department and the Mental Health Association, and so on. And so what you learn from that, what you get from that is through the RC survey is an RC score, Relational Coordination Score, which tells you about the strength of the communication and coordination between these agencies. And as you see from the key down the bottom, you can see where there are strong relationships, and those are the boxes that are in green, and where there are moderate relationships in blue, and then where there are weak communication and coordination dynamics between the agencies. And so on the one hand, it creates a baseline. On the other hand, and what we've done is we are taking these results and then we use it back with the partners and say, okay, so through your interviews and through the RC survey, you have told us about how frequently or often you communicate with these other agencies. If what we want to do to operate at the best level and to achieve the goals that we need to identify ways in which you can communicate more frequently. And so we fed that information back to each of the partners in a meeting. We've been working with supervisors more recently, referring them back to the MOUs in terms of trying to reinforce what they had identified as the ways in which they can operate efficiently and effectively. So the survey allows you to identify those areas of improvement, and it serves as a diagnostic tool in helping to improve the collaboration over time. The goal over the course of the whole SPI would be to improve communication and coordination through these agencies and support the institutionalization of those relationships so that, again, if we have staff turnover, their work together will continue. So currently, we just finished up doing our co-op stakeholder interviews with the representatives from those agencies to gain some additional insight to what we learned through the survey. And it's important to note that as you collect data over time and people change roles and things like that, that you might get different kinds of information. But 1 year after administering the RC survey, we conducted these interviews, and you could see that it looks like that the team is in a better place. One person said that they feel very solid and stable right now. And again, I just want to reiterate that they had significant staff turnover challenges early on, but there's some optimism in terms of how the partnership is developing and where they are going. But of course, like all kinds of partnerships, there are challenges as well. So we learn about those through the RC survey, and we can use that information, but also we've learned about some other areas through the interviews, and that has to do with sort of sorting out different things like what are our roles, where do we fit, and then also in this instance, and like most of these agencies where there are different agencies who have different philosophies, there are a lot of questions about what our roles are and the chain of command in terms of who works for who, and so that's something that's really being worked out right now. But we're learning about sort of those cultural and structural challenges, but we really need to figure those out if we want to build their capacity and sustain that capacity to work together. So we think there is a lot to learn from this collaboration and the use of RC in this project in Lowell where we've got these different agencies. We also have really, all of the partners and the researchers have appreciated the action learning approach that we have fit into this relational coordination approach. So we have a lot that we want to focus on in the coming year, but we think that the relational coordination model and the tool is really fitting for the SPI work in Lowell. So thank you.
Thank you to our presenters, and we now have time for some Q&A. So our first question is for Shyla, and the question is, in Atlanta there are lots of formal structures intermingled with nuanced collective behaviors to build trust and mutual respect, which seem to be precursors to getting any work done. It sounds like shared rewards and accountability structures are important here in addition to shared goals and a variety of work process interventions. Shyla, have you thought about differentiating between interpersonal from role-based relationships within the collaborative?
Hi, thanks for the question. So we mostly just use the Wilder survey to measure the formal structure of the health of the collaboration. We don't particularly do any interpersonal between one person or another. But some of that comes out definitely amongst the whole group.
Thank you, Shyla. We also have a question for both Shyla and Brenda, and that is, how have the collaborative groups reacted to being surveyed about the health of their collaboration?
So this is Brenda. For the most part, I think people have been accepting of it, and I think, I hate to sort of sound like a broken record, but I think for us and for them, the challenge really has been around the staff turnover and the delays in hiring people that, often come in municipal government. And so for the most part, I think that there has been acceptance, and we've been very, very conscious to make sure that we get that information back to everybody and that we frame it in a way that's mostly about how do we use this to improve the work that you're doing. And so my own personal assessment, maybe others in the Lowell project would say differently, but it's been pretty well received, I think.
Hey, this is Shyla. So our experience is kind of similar. I actually use this across several different projects, and I have not gotten any pushback on it. It's anonymous, and it's always explained in the same way that Brenda talked about, that it's for the development of the collaboration and what they'll get from it and recommendations. And then, the first time that you deliver those results and you talk to them, they benefit from it, they see it, they digest it. I think the same way with the communities and taking information back to them, that people want to know their own perspective but framed within the larger group, and always using that to improve and be more efficient and effective. This just doesn't really have any drawbacks. So all of my projects, everybody has been willing to do them, but like I said, they don't identify anybody or any particular agency. It's just the whole task force.
Thank you to both Brenda and Shyla. Barring any other questions, I think we will go over to Chip for some closing remarks.
All right. Thank you very much, Emma. And once again, thanks to all of our presenters and participants today. I would like to draw our attention to a few points that I think we can glean from these presentations and some general issues regarding collaboration that are central to our work in SPI. The overall theme I see in all of this work has to do with the advancement of collaboration principles and practices, and a growing sophistication in how we think about collaboration, implement collaboration, and study it. As Hildy noted, collaboration is an advanced form of police-community interaction. The essential elements of collaboration have been articulated by Hildy and SPI and by others. I see this as an advancement. When we define our concepts in detail and articulate the essential elements of a phenomenon we are interested in, we are putting meat on the bone, so to speak, and helping move the field forward. We heard today about collaboration goals, collaboration structures, collaboration processes, and collaboration dimensions, those unique elements of collaboration that combine to make it work. This, too, evidences new sophistication regarding how we are conceptualizing and thinking about collaboration. We learned about different approaches to actually measuring collaboration and how well, or not, things are going in a group effort. Most specifically, we heard about the other collaboration inventory in Atlanta and the relational coordination model in Lowell. Making measurements of collaboration and actually putting those to use to improve our SPI initiatives is a significant and very positive development in our view. Again, this indicates that we have become more sophisticated in how we promote and study collaboration. Permit me to leave you with two closing thoughts on collaboration. These are principles that we have espoused from the early beginnings of SPI. If we're serious about collaboration, we should treat it like an outcome variable that we measure and analyze, just like we do with crime data and other organizational measures. We should also plan for and dedicate resources toward collaboration in our initiatives. That's what makes it work and helps prevent collaboration from essentially becoming a buzzword. Regardless of what our policing strategies are, whether they are place-based, people-focused, intelligence-led, problem-oriented, or something else, they all depend to some extent on effective collaboration, both inside and outside the organization. So in our view, collaboration underlies nearly all of what is done in the name of policing. That's why we spend so much time on it, and that's why we are pleased to be able to demonstrate, through the work of these great people, how collaboration is improving and advancing in SPI. That concludes our webinar for today. Thanks again to BJA, to our presenters, and to all of our participants. Take care, everyone.